Great. Thank you, Dr. Crowther, and to Ash for the opportunity to highlight our abstract today. So I'm going to be speaking about CASSINI, which is a large multinational trial looking at the primary prevention of blood clots in cancer patients who are starting a new systemic therapy regimen. So cancer patients are known, this has been known for over 100 years, if not longer, that cancer patients often suffer from blood clots. And blood clots are typically venous clots, so deep vein thrombosis and pulmonary embolism, but they can also be arterial clots, such as stroke or myocardial infarction. And once those clots happen, patients suffer a lot of consequences. So they can die from the clot. That's obviously the worst consequence. But there's also, even if that extreme consequence doesn't happen, there's also other bad things that can happen. People can be hospitalized. They can suffer morbidity from the clot itself. Their chemotherapy treatments may be delayed. And there's a lot of resource utilization that can occur. In 2018, most of our cancer treatments take place in the outpatient setting, and so most clots occur in the outpatient setting. And from a public health perspective, that's really important because almost all our efforts at preventing blood clots have focused on the inpatient setting. So anytime, if you've had a family member that's admitted to the hospital or underwent a big operation, they always get a blood thinner when they go into the hospital unless there's a bleeding issue. And if you have a hip or knee replacement, you get something to prevent blood clots afterwards, but those are for short time periods. Cancer patients are at risk for blood clots for a long time period, roughly 6 months at least, while they're on systemic therapy. There have been other randomized trials that have addressed this issue, and these two I highlighted here are the two sort of largest ones. And in both those studies, they were actually statistically significant in reducing blood clots, but the event rates were low. They were under 4%. And one of the things we calculate using these numbers is how many patients have to take a drug to prevent a blood clot for one of them not to have a blood clot. And the number, that's called the number needed to treat. And the number needed to treat is pretty high based on these studies. Around 50 patients would have to take, these were both injectable drugs, so 50 patients would have to take an injection every day for one of them not to get a blood clot. About 10 years ago, my research colleagues and I developed a risk score that could help predict which patients were at risk for getting a clot. And that's helpful because if you target your approach of primary prevention to high-risk patients, then the benefit would be greater, and so the clinical benefit to patients would be greater. And that was really our hypothesis going into this clinical trial. So CASSINI was as I mentioned, a multinational, multi-center study. It was randomized, it was double-blind, it was placebo-controlled. We took patients with all, so this is really applicable to the larger cancer population. We took patients with all types of solid tumors and one heme malignancy lymphoma, and we took them at the start of starting a new chemotherapy regimen. So if they could have been on chemotherapy before, but if they're switching over to something new, or if they were a new cancer diagnosis and they were starting on something new, that's the time when we enrolled them on this study. We didn't interfere with their treatment regimen. We just said, let's also focus on preventing blood clots. But because we wanted to be targeted towards which patients to prevent blood clots in, we only focused on patients at high risk for events, and we defined that high risk based on this tool that we had developed before, known in the literature as the Khorana score, and we used the cutoff of 2 or higher. So we randomized about 841 patients. Half of them got Rivaroxaban, 10 milligram once a day, which is a direct oral anticoagulant. It's available for treatment, and as you heard from Dr. Duquette, for prevention of events after atrial fibrillations. It's a drug that's already out there. We did 2 sort of additional things. One is that before randomizing patients, we did an ultrasound of their legs to make sure that they didn't already have a clot. And we have some findings that are actually very interesting based on that. And then while they were on the study, we also checked their legs to make sure they didn't develop a clot while they were on the study. And this kind of systematized collection of this data. So here's the sort of results, and I'm going to walk through this slide in a little bit of detail just so everybody understands. So our primary analysis was the full 180-day period. So the goal was take this drug for 6 months, and let's see if we can prevent blood clots or not. The problem was that this is a cancer patient population. It's a sick population. They're getting chemotherapy. Many of them were switching chemotherapy drugs, or they would progress on their chemotherapy and switch to a new clinical trial of a different drug, and then they would come off of this trial. The bottom line is about half of patients did not take the drug for the full 6 months. 50% of patients on the placebo arm and about 44% of patients in the Rivaroxaban arm. And so if you look at the primary analysis period, the rate on the placebo arm was high. It was 8.8%, and it dropped to about just under 6% for the rivaroxaban arm. But this difference, even though there was a reduction, it was not statistically significant. And that's largely, at least partly, because nearly 39% of events occurred in people who had already stopped taking the drug. It's not unexpected, because we know patients, if you're not going to take the drug, you won't obviously be able to prevent a clot. The prior trials all focused on the on-treatment period, which is the duration of actually taking the drug. And we had pre-specified that as sort of one of our key analyses. And in that analysis, we found 6.5% of patients on the placebo arm had a clot, and on patients who are taking rivaroxaban, 2.6% of patients had a clot. So that's a more substantial risk reduction, and it's also, the p-value is 0.007, so more impressive reduction that way too. The one additional thing I would mention, which I thought I had the slide of, but I don't in this package, is that, remember I said we did ultrasounds of the leg before patients started on events? Well, 4.5% of patients already had a clot before they even started on the drug. And so those patients were not randomized. We just sort of took them off the study, and their physician treated them for their clot. And that had some effect over here, because as you can see, the first 3 months, because we had a pure thrombosis-free population starting out, many patients did not develop a blood clot, and I think that might have implications for clinical practice as well. A couple additional findings that we had. These are all pre-specified analyses, so these are not post-hoc analyses. And we had pre-specified that we wanted to look at not just thromboembolic rates, but many thromboembolic events can lead to death, as I mentioned earlier. And so we had a pre-specified composite endpoint of both the primary endpoint with all-cause mortality. So if anybody died on the study, we added all of those deaths to the endpoint. And here also you saw a substantial reduction in events, so 29.5% down to 23.1%. That's a 6.5 absolute risk reduction. Hazard ratio is 0.75. This p-value is 0.03. And I think that adds to the potential clinical benefit that patients could observe from being on a primary prevention approach. Now, in any primary prevention approach, safety is key. And thankfully, we did not observe many abnormal safety signals. So our big primary safety endpoint was major bleeding. The incidence was quite low, of 0.99% in the placebo arm, up to 1.98% in the rivaroxaban arm. And the secondary endpoint was clinically relevant non-major bleeding. And that too was quite low, 1.98% in placebo and 2.7% in the rivaroxaban arm. Again, this is a population of cancer patients, many with GI cancers, many undergoing systemic therapy with chemotherapy and low platelet counts and so on. So overall, we found this bleeding incidence to be low. So how do we add up all these sort of benefits and risks of primary prevention in this setting? So I'll come back to that number needed to treat that I referred to earlier. So if you look at just the day 180 endpoint, so whether they took the drug, did not take the drug, if they stopped taking the drug after a few days, count all those patients, it's still better than where we were in the prior trials, so from 50 down to 35. But remember, those prior trials were all on treatment. They weren't, they didn't count any events if you stopped taking the drug. So if you do an apples-to-apples comparison, that's actually even better, 26 from the benchmark of 50. So 26 patients would need to take the drug to prevent one blood clot from happening. And then if you include some of these additional secondary endpoints, and tomorrow I'm going to have sort of a slightly updated graph. If you include all the secondary efficacy endpoints, I'm showing here 20, but it's actually 17 if you include all the arterial endpoints. And so, the clinical benefit sort of continues to improve if we include the secondary endpoints and the primary endpoint. And we are not discussing mortality here, but there is a potential reduction in mortality as well. The number needed to harm is pretty steady because it's always on treatment. So it's 101 to prevent to have one major bleeding. That means if 101 patients took the drug, one of them would have a major bleeding episode. And if 135 patients took the drug, then one of them would have a clinically relevant non-major bleeding episode. And so in balance, that looks like there's clear benefit to patients from this primary prevention approach. So to summarize, rivaroxaban significantly reduced VTE and VT-related death during the on-treatment period, but not during the full study period. And that's largely because of high rates. These patients remained at high risk of clots after stopping the drug. The incidence of major bleeding was low. And the risk score cutoff that we chose of 2 or higher did in fact identify patients with a high rate of thrombosis. So as I mentioned, 4.5% at baseline, 8.8% of the primary endpoint events, 1.9% of the other thrombotic events, 1.7% of arterial events. So total thrombotic rate of 17%, which is really quite substantial in a 6-month time frame. And because nearly 1/3 of these events were at baseline before patients had even started on chemotherapy and before they even started on the drug, we wonder whether baseline screening should be considered in patients who are starting systemic treatment. Regardless of that issue, I think given our findings, we believe that future recommendations regarding primary prevention of thrombotic events in cancer should be informed by the findings of this study. Thank you.